that CBT and atypical antipsychotics are effective augmenting agents. Now, actually speaking, beyond these two statements, there is nothing new that has happened in psychiatry as far as treatment of OCD is concerned. We know SSRIs work, we know CBT works, and in some people, maybe a quarter of them, slow dose antipsychotics may be useful. Beyond this, actually speaking, there is no great evidence that other treatments really work. I come to that actually later on. It's also a well-known fact that treatment resistance is not unusual in OCD. In fact, close to about 40% of the patients become treatment resistant, and even those people who respond have a varying degrees of kind of symptoms and they don't really remit completely. So it essentially we're talking about illness where symptoms may not go away completely even if they respond. Let me start with the most common error that we all make. Not choosing right drug. You might wonder what is that you're talking about. You just now said that SSRIs are a treatment of choice and what is there to choose among the SSRIs? Yes. In a way, it is true that there's nothing to choose as far as their efficacy is concerned. Now, but however, if you're aware of a meta-analysis which came in Lancet 2-3 years ago, it was a meta-analysis, in fact, a network meta-analysis which included CBT, various SSRI medications, and even CBT. And it came with it concluded that all SSRIs are equally effective, and clomipramine is no more superior to SSRIs in treating OCD. We all know, we all believe, and perhaps would like to believe that there is a medicine like clozapine which is waiting to be given to patients with OCD when they don't respond to SSRIs. But clomipramine is not the clozapine of OCD, at least in terms of its efficacy. Now, keeping this in mind, how do we choose a medicine? Now, it is not a great idea to initiate treatment with clomipramine or even adding it to SSRIs. I've seen many people adding a 50, 75 milligram of clomipramine to, say, fluoxetine or a fluoxamine or a paroxetine. Now, what you really end up having is that even if that is not a monotherapy, you have more side effects because most of these drugs increase the clomipramine levels. Then tolerability is poor, and then it contributes to dropouts and poor treatment adherence. In fact, I get to hear from patients very often, why did you start treatment? I said, I was sedated, I was constipated, I couldn't do anything, I just stopped treatment. Now, my point is, why do you want to start your treatment with clomipramine when actually it's not superior to SSRIs? And there is another favorite that I've come across with most clinicians, fluoxamine. There is a belief that fluoxamine is a specific anti-obsessional SSRI, whereas other SSRIs are basically antidepressants, which also work for OCD. Now, the fact is that there is no great evidence to show that fluoxamine is much superior to other anti-obsessional drugs. Not that it does not work, but not superior. Why is it very important? Because you prescribe somebody a fluoxamine which costs 50 rupees per day, the chances of them not taking are very higher, particularly if they have some side effects. So there is no great rationale actually to start treatment with clomipramine or for that matter with the fluoxamine, because it might, in my personal view, contribute to poor tolerability and then dropouts. Also, like I said, there is no great rationale to start with the combination of two SSRIs or SSRI plus an antipsychotic. In fact, these days, I very commonly see antipsychotics sometimes in clozapine 25 milligram added to an SSRI as a matter of routine, like adding a clonazepam. Now, I really don't understand why this happens, but I can see this happens because antipsychotics are now sold as a very effective anti-obsessional, which is actually partly true, but they are effective only as an augmenting agent in about a quarter of patients. How effective? Yes, you might have a slight improvement in OCD symptoms, but not a great improvement. So we need to be very careful what drug we choose. And I personally would prefer something like a fluoxetine, sertraline, and escitalopram. They're been in use for a very, very long time. They're better tolerated, and I think they're cheaper. So I think we need to really start with those medicines and definitely not with clomipramine. I think I summarized this particular slide previously. Even Indian Psychiatric Society clinical practice guidelines also do not really talk about starting with clomipramine. It recommends to choose an SSRI for an individual patient based on factors such as previous response, comorbidity, tolerability, acceptability, adverse effects, cost, most important, and drug interactions. Now, that is about the choice of drug. Now, not following the right dosing is the next most important issue in the treatment of OCD. For regions that are unclear, I would say there are several possible hypotheses people have talked about. Lower doses of SSRIs really are not all that effective in treating OCD. This is something that we all know. Now, using subtherapeutic doses always contributes to poor response, and when that happens, we keep changing medication. So it is not uncommon to come across patients who have been in treatment for many years, but what has happened is they have received subtherapeutic dose of SSRIs for a very long time, or subtherapeutic doses of multiple SSRIs contributing to side effects. So I think we should choose a right drug and use them in appropriate doses. At the same time, when I say that SSRIs need to be given high doses compared to the dose that we use to treat depression, there is also at the same time no evidence to use ultra high doses. 120 milligram of fluoxetine, 160 milligram of fluoxetine, 80 milligram of escitalopram are often given either out of sometimes the belief that very high doses work, or because patients don't respond, we keep increasing the dose. Now, this again is a problem because as you increase the dose, efficacy does not increase, but you actually enhance the side effects. And in fact, at that dose, 80 milligram of escitalopram, you might even have a cardiac side effects, but because we also know that citalopram has side effects, cardiac side effects, and 120 milligram of fluoxetine is a very, very high dose, but this is not an uncommon prescription. So we need to be very clear that we need to use the right dose, not a low dose, but not very, very high doses. This preoccupation with very, very high doses has come from a very small body of literature which examined the efficacy of sertraline. Now, there is a small study in Journal of Clinical Psychiatry some years ago which tested 300 and 450 milligram of sertraline in that range versus 150, 200 milligram, and they found some statistically insignificant, I am underlining statistically insignificant improvement in the severity of the illness. And that has led to using SSRIs liberally in a very, very high doses. So I think inappropriate dosing is also one thing that I would strongly recommend against using in OCD. Now, the other thing is that since we think that, which is also true, that SSRIs take long time to work for OCD, sometimes as long as 3 months, we don't want to waste time and we start increasing the dose rapidly. So rapid dose escalation is another problem. It contributes to greater side effects and poor tolerability. Now, I will give an example. If I have to use fluoxetine, I will use 20 milligram every week and reach up to 60 or 80 milligram by about third week. And I would give it for another 8 to 10 weeks, amounting to a total of about 3 months of an adequate trial with fluoxetine. I would perhaps similarly do the same thing with fluoxamine and escitalopram. I would generally take about 3 to 4 weeks to escalate the dose, depending upon the tolerability that the patient has and the side effects. Now, if you increase the dose rapidly, patients may drop out. Now, in fact, some patients are very, very sensitive to SSRIs. They start complaining of agitation, restlessness, anxiety, insomnia, and that is good enough for patients to simply start treatment. They move on to somebody else, or they simply lose confidence in the treatment itself. In any case, drugs take longer time to work, and those initial 1 or 2 months, patient is only suffering from side effects and not the benefit. So I think we need to be very, very careful how we escalate the dose. Now, having said that, the greater efficacy with higher dose of SSRIs now has been established very clearly with escitalopram, fluoxetine, and paroxetine. For example, escitalopram 20 to 30 milligram is distinctly superior to 10 milligram. 10 milligram can often be a good antidepressant dose. Similarly, fluoxetine 60 and 80 are much better than 20 and 40, and same is also the case with paroxetine. Now, we assume that it is the case with other SSRIs as well, although there are not many studies. Okay. So, what do guidelines recommend? Guidelines obviously recommend treatment with higher doses, but if an individual patient, most important, if an individual patient is not able to tolerate higher dose, Low to medium dose also is important, because while it is very common to use, say, for example, 60 to 80 milligram of fluoxetine, it is also incorrect to believe that 40 milligram of fluoxetine does not really work for OCD. At the same time, 20 milligram of escitalopram may be good enough. You don't have to really go to 40 milligram in some patients. I think we need to be very flexible in this approach. Okay? And the guidelines continue maximally tolerated doses for at least 12 weeks for judging its efficacy. Okay. So if you look at our Indian Psychiatric Society guidelines, you have the best evidence for escitalopram and what is the recommended dose, 20 to 30 milligram. In fact, I rarely ever prescribe anybody beyond 30 milligram of escitalopram, but somehow people seem to mistake escitalopram and citalopram for citalopram and give 60 and 80 milligram of escitalopram, saying it is similar to citalopram. Now, fluoxetine, the evidence is only for 60 to 80 milligram. Fluoxamine, 200 to 30 milligram. Paroxetine, 40 to 60 milligram. But I think if we use sustained release preparations in India, you can go up to 75 milligram. Sertraline, 150 to 200. Citalopram, 40 to 60. Beyond 60, in fact, there is FDA warning. One needs to be very, very careful in using high dose of citalopram because of its cardiac side effects. And clomipramine, in fact, 150 is a good enough dose for most patients. Beyond 150, patients really experience many, many more side effects. And then side effects become a bigger problem than OCD itself. For example, I can give you an example of a patient who has severe contamination PS and spend a lot of time in the bathroom evacuating the bowel. So clomipramine doesn't do him any favor. They spend even more time because of a very, very severe constipation. Of course, you can go as high as 300 milligrams, but generally it's advisable that we stop at 150 for about 2 months before we really escalate the dose. What we often don't do is that because the upper dose is 300 milligram, we have a tendency to rapidly build up to 300 milligram. 300 milligram of clopramine, 225 milligram of clopramine is quite unpleasant for the patient. And remember, the risk of seizures is almost 6% at 225 milligram per day. Venlafaxine has less evidence, but yes, it can be used if SSRIs don't work. Okay. Now, this is about the right choice, the dosing of the drug, and how to escalate. Now, the other problem that we often see in our practice is a premature withdrawal of a drug and dose reduction during maintenance treatment. Now, OCD is a chronic illness, whether we like it or not. Even people who remit completely, when you withdraw medicines, the relapse rates are very high, including the Indian Psychiatric Society guidelines. All the guidelines tell you that you continue for at least for about 1 to 2 years after achieving full remission or recovery in a newly diagnosed patients. But most of us, I think these days, have stopped seeing newly diagnosed patients. I don't know. I don't see them anymore. You see patients who have been ill for many, many years. You also see patients who have been, who have had multiple relapses, or people who have had incomplete remission. So this rule often, this 1 to 2 years of treatment after remission, unfortunately, does not apply to majority of the patients who have already been on treatment in the past. In fact, at best, it might apply to patients who are newly diagnosed and not the patients who have already been on treatment. We need to be very, very clear about this, because we have seen from our own data, when there's a partial remission and when there are still symptoms, if we withdraw SSRIs, there is a very high chance of a relapse. So it's important that we talk to patients that treatment is lengthy and it is enough that they should be happy that they work, because they don't work for 50% of the population. Okay, I often talk to them saying, look, there are many patients who take medicines and they want them to work. They don't work, but fortunately the medicines are working for you. Why do you want to take this chance? Typical example is somebody, let us say, in a first year degree or when they join engineering college, they come with a diagnosis of OCD and you give an SSRI, and then maybe in 6 months time, many of them do improve and they want to discontinue. I tell them, look, the guidelines tell me that I give at least for a year, but I would say you have been having an illness for 2-3 years now, you have suffered enough. I would probably not want to stop medicines till you at least complete education. Let me see whether we can taper it off slowly later on. So it is not a hard and fast rule that after 1 year you have to stop medicines. It has to be done in consultation with the patients, and it has to be a very, very slow taper. But one thing is very clear, indefinite treatment is required for people who have a chronic severe OCD, those who have past history of relapse upon discontinuation, those who have partial remission, they improve, but they're still symptomatic. People have comorbidities such as obsessive compulsive personality disorder, other anxiety disorders, and depression, and adults who report childhood onset of OCD. So I think we need to be very, very careful when it concerns withdrawal of SSRIs. I'm one of those who is not fond of withdrawing SSRIs and patients respond to it. When patients respond to SSRIs, let me tell you, they respond much better than the so-called standard CBT treatment. Some of them are very, very good responders. So we need to be very, very careful withdrawing them. So I don't make that mistake. I usually engage them in conversation and negotiate with them. Now, if I do want to reduce medicine, somebody is totally asymptomatic for 2 years, 3 years, they want to take a chance. How do I do that? Now, I do it very slowly. But most important thing is that during that 1 to 2 years of maintenance treatment, don't reduce the dose unless they have very bad side effects. The dose that gets the patient well is a dose that keeps the patient well. There is no evidence at all, like in schizophrenia, where you have an option to reduce antipsychotics of an acute phase of psychotic illness, and 6 milligram, 8 milligram of risperidone can be reduced to 3 or more 4 milligrams, and you can have a maintenance dose. Unfortunately, in OCD, we require the same dose that actually contributed to improvement. And so, try and keep at least a moderate doses. So I think this is something I already spoke about. I will not repeat it. Now, one of the major issues in treating OCD is, of course, the poor treatment adherence. One, not because SSRIs cause so many side effects, because there's a lag in the onset of action, and then nobody wants to take medicine indefinitely. So what contributes to poor adherence? Now, most important thing is that not knowing enough about OCD and its cause. Now, there are two kinds of people who Google and come and talk to you that their illness is never going to be cured because that's what is written in the Google. OCD is a chronic, waxing and waning illness which rarely remits. And many patients know this. They come and tell you, but it is not entirely true. I mean, you know how to read that particular statement. Patients don't know that. In fact, a large number of patients, freshly diagnosed, newly diagnosed OCD patients who do not have too many comorbidities, who are premorbidly well adjusted, and they're drug naive, or when they come to you, 60 to 70% of them do reasonably well with anti-obsessive. Some of them are able to even withdraw medicines after a couple of years. So I think we need to be very, very careful, but at the same time, we need to tell them that it is by its nature, it has tendency to relapse and it can become chronic. So we need to keep at least treat you for sufficiently long. Now, they also have unrealistic expectations. They want quick recovery and fast response. Now, it's a good practice to tell patients, look, I'm escalating the dose. I'm sending you back with a prescription. If you don't have problems, you don't come and see me for 3 months. I do this very routinely. Now, it might amount to losing 2 or 3 consultations in between. That's okay. They don't come and bother you, because after 1 month, if you call them and then, there is no improvement, you are tempted to change the medicine or do something with the dose unnecessarily, because patient also says something. And when a patient comes to, in a month's time, you have collected fees. I mean, you have to do something. I mean, it's human. Okay, I will add 1.5 milligram of risperidone. I will add 25 milligram of clomipramine. All these kinds of tendencies come to our mind. So I usually don't ask them to come before 3 months unless there is a real problem. Okay. Not knowing about common side effects is also one of the common reasons why there's a poor adherence, and not addressing side effects in advance, explaining them the common side effects is one issue. But there is another side of the story, is that sometimes people have exaggerated concerns about medications, and OCD patients, by their very nature, their threat perception is very, very high. They're extremely concerned about long-term consequences, and if are in the childbearing age, we're extremely worried about heterogeneity. We know that long-term consequences of taking SSRIs are not great, and then they're not really all that bad teratogenic drugs, so we need to really talk about them. And of course, lastly, poor insight contributes to poor adherence. So you require family members or somebody to really supervise medications, or patient might have to get into therapy so that you work on their insight. So these are the very common causes of poor adherence we need to keep in mind, and we should not make mistake of not addressing these factors, because if you don't address these factors, patient's life will drop out or they don't improve. Now, there is another thing that There are about 5 or 6 SSRIs. There is a clomipramine, there is venlafaxine. Now there is a mirtazapine if people want to prescribe. Now vortioxetine has come, vilazodone has come. How many similar looking drugs? There are about 10 of them. So you can keep on giving them for about 10 years. And then you have so many atypical antipsychotics. You have a glutamatergic drugs, memantine, N-acetylcysteine. Now you want to give ketamine. Then you want to give ondansetron, granisetron. All of them are of a no proven efficacy, unfortunately, beyond SSRIs. So there is an excessive reliance on a series of augmenting agents. For years, patients have received only medications, thinking that these medicines would make a lot of difference. So these are the pharmacological augmenting agents we know. Of these, reasonably good evidence is there only for aripiprazole and risperidone in the doses that I have mentioned, and this is straight from our clinical practice guidelines. Now, all other drugs, memantine, riluzole, N-acetylcysteine, lamotrigine, 5-HT3 antagonists, their evidence is not great. Although when you say B, it looks great. What it means B is that when you do a randomized control trial, there's 25% reduction in Y box, and some trials nowadays they're using on 20% reduction of Y box. This may not always mean much to the patient. So there are not many good augmenting agents. So there is no point in trying one after the other endlessly when there is an alternative effective treatment for OCD other than SSRIs. So we should not make that mistake of doing this for years together. We actually examine how good is risperidone in treating OCD. This is not a kind of a RCT, but we just looked at our own prescribing practices in our clinic. Fortunately, we have Y box rating for everybody. You can see in that about a quarter of the patients reported improvement with OCD. And what is that improvement? 25% reduction in Y box after adding to an SSRI. So 25% reduction in 25% of the patients is not a fantastic drug, be it aripiprazole or risperidone. So while they are useful augmenting agents, we should not overstate their importance. Now, similar case with aripiprazole, we examined it in another study. It had, in fact, many more people had dropped out of aripiprazole trial than with risperidone, but both of them had a similar kind of a response rates about 30%. So you can expect about a quarter of your patients who receive atypical antipsychotic to show a partial response. I think that's the best statement that one can make about the efficacy of antipsychotics. And we also don't know how long to give them once they work. Now, common sense dictates that you continue them indefinitely like you continue SSRIs, because there is no data on the maintenance treatment of antipsychotics in OCD. And once a patient improves in a difficult disease like OCD, you don't want to withdraw them. So once that is done, we need to start worrying about long-term side effects and neuroleptics as well. So while we all use them, I think these are not panacea. But the reality is that as an augmenting agent, the best treatment is actually CBT. Well, now CBT involving exposure and response prevention is the first line of treatment. We all know that, but it is also the first line augmenting agent in treating OCD, and not risperidone or not aripiprazole. Okay, I think this is something that we need to keep very much in mind. So, not employing cognitive behavioral therapy or exposure response prevention, instead trying a series of medications with doubtful or dubious efficacy is, I think, the greatest disservice that actually we can do to patients when there is an effective treatment available. So this is a mistake I would perhaps avoid if there are facilities to administer therapy. And increasingly, there are so many psychiatrists, psychologists everywhere. Every medical college has a post-graduation teaching program. I think now there are slightly more facilities to offer therapies than it was some years ago. I think is an important option that we need to keep in mind. In fact, it has a greater effect size compared to SRIs. In fact, one study has shown that even when patients don't respond to risperidone, and then you add CBT, even those patients respond to CBT than risperidone. So I think we need to keep in mind, we ourselves had done one study in SSR resistant OCD, and CBT was quite effective. Now, I will show this study to everybody to just put things in a perspective that, exposure response prevention alone, okay, was good enough. And addition of chlorpromine did not make a much difference in this study. This study has many other uh, methodological issues, but let us remember that CBT was superior to chlorpromine in this particular study, and additional chlorpromine did not really make a lot of difference. So that actually should make us think twice when we don't recommend CBT. Now, this is another, again, trial which showed how good CBT is compared to stress management. I think the most, I will show this slide. If you can look at here, in a patients who are partial responders to SSRIs, when you add CBT, the response was 70% compared to stress management. So number needed to treat for responders was 2 when you add CBT. Okay. And when there are minimal symptoms and somebody is in remission, NNT is 4. So obviously, this is a much superior treatment option. We ourselves had done one prospective study of CBT in people who had not responded to multiple SSRIs, and many of them had actually even received multiple augmenting agents. You can see that the response and remission rates are very high post-treatment, and it continued to be high even at 12-month follow-up. That obviously shows that a good expert CBT therapy is a good augmenting agent. So we need to add as quickly as possible, rather than keep it as a last option. Now, while we talk about CBT in great detail, okay, I think I did speak something about this in my last talk when I spoke about forbidden thoughts, but I would quickly go through. CBT is also a treatment. It has to be administered well if it has to work. Okay, CBT is not about making a patient buy a diary and then make a list of symptoms and then ask them to go home and practice it. It doesn't work like that. Now, most patients have a problem in that they don't understand why they are practicing behavior therapy. If they don't understand the rationale, they don't participate in therapy, because what we tell them is what actually everybody tells them: don't wash, don't clean, don't check. How are we different from others? So unless they know the rationale and a philosophy and a theory behind it, the language that they understand, the next step is very, very difficult. I think this is something that we need to really address clearly. And the other reason is that when you do therapy, we don't really take it to logical end. We keep, once we achieve some improvement, we tend to drop it at that, because patient also is uncomfortable in handling the most threatening situations. And we also lose interest after some time, our patients drop out. But having, not going far enough is actually an important reason why CBT does not work, and there may be quick relapse. And when patients show reluctance to go up in the hierarchy, when you do an exposure, it is important that we keep reviewing the rationale behind therapy, keep discussing about the reason, how it could lead to a relapse, and you can revisit the same exercise again and again. They need a lot of encouragement, and in some situations, even in fact, therapists might themselves do an assisted exposure so that patients get confidence and they move on with the next level. Now, the other important thing is that exposure response prevention is not same as systematic desensitization. In systematic desensitization, you are exposed to a particular threatening stimuli, and then you are taught relaxation. Okay, because the concept there is one of reciprocal inhibition. Whereas exposure, the gold standard treatment for anxiety disorders and OCD, actually relies on habituation and disconfirmation of fears when actual exposure occurs. Now, for that to happen, then we should make sure that patients don't employ any techniques of distraction. Thought stopping actually is not a treatment for OCD. It doesn't really help, because it prevents habituation. And then many patients have a tendency to offer resistance and control to their obsessions. What we need to work with them is, you offer resistance and control to compulsion, but not to obsession. And don't please teach them relaxation training when they get anxious. Does not prevent, it prevents habituation. So these are the common inappropriate techniques that are often employed when you do CBT. Now, reassurance. Now, particularly in people who have these forbidden thoughts and pathological doubts and checkers, reassurance seeking is a very, very common thing. Sometimes they reassure themselves, but often family members become part of this reassurance exercise. They tend to reassure excessively. And I've also seen many inexperienced therapists fall into this trap And the whole session is about reassuring them. Initially, they think that they're clarifying concepts. After some time, patients start asking same questions again and again, so that you reassure them that nothing terrible really happens. It's a trap. So you need to be very consciously aware of it, and after some time, give a feedback to patients as to what they're getting into and how they're making you also do things which their family members also do. In fact, it is a very, very common thing that we see, at least in severely ill patients. So the whole session can get simply sabotaged. I think we need to keep this in mind when we handle reassurance. Now, sometimes exposure therapy alone does not work. You will also require to do a cognitive therapy to modify belief systems, because sometimes if you don't modify the underlying beliefs, such as exaggerated threat perception, infinite sense of responsibility, or thought action fusion, or beliefs toward perfectionism, long-lasting changes may not be seen. And poor insight patients in particular benefit from a cognitive restructuring and not just ERP. So I think this is a cognitive part of CBT has to be kept in mind when ERP alone is not good enough. Okay. Now, other important thing that happens in therapy is that we don't deal with cognitive compulsion and mental compulsions. Now, not dealing with mental compulsion is a sure recipe for a failure of CBT. In fact, some patients are so accustomed to performing mental compulsions, it almost has become an habitual response. Whenever they get a negative thought, they immediately perform a compulsion. In fact, they have a problem in differentiating obsession from compulsions after some time. They become habits more than anything else. So, failure to identify and handle mental compulsion is a major limitation of cognitive behavior therapy. And to do that, we need to really educate patients well in advance what mental compulsions are and how they're similar to other overt compulsion. And also in the course of therapy, we need to keep a constant watch on patients employing mental rituals or re-emergence of mental rituals. Now, the one part that often doesn't get handled in therapy is a family accommodation. In fact, if you look at the childhood literature on OCD, in fact, childhood CBT or CBT in children with OCD rarely ever happens without involving family. Now, it is increasingly recognized the same applies to patients with adults, particularly if they have severe OCD with very prominent compulsions when they involve family members in the rituals. In fact, many family members usually participate in avoidance and compulsion. They change their routine family structure. They do everything to accommodate patient symptoms. And they think that they're helping patients, but actually they're helping in maintenance of symptoms, and they also end up performing proxy compulsions. So whenever there is a family accommodation, when I say family accommodation, family members changing their family routines to accommodate OCD symptoms, family members performing proxy compulsions, family members participating in reassurance, in such situations, family members should be involved in therapy because they lack the knowledge of the role of family accommodation in the outcome of OCD, and they believe that they're helping the patient. In fact, if you handle family accommodation, you also decrease significantly conflict of the patient, and in fact, the outcomes are much better when family members are involved in therapy. At least we do this very routinely in severely ill patients whom we admit for treatment. Okay. Now, this is one study that we did some years ago, where we followed up naturalistically patients for 1 year. You can see that patients who had high family accommodation, FAS 1 to 13, that's a scale family accommodation, people who had high family accommodation did not really respond well to a series of SSRI medications mostly, and some of them even CBT, whereas for those who had family accommodation lower at the baseline tended to improve treatment. So I think this is one important study which points out how it is important to handle family accommodation. We should also discuss relapse. When we complete therapy, we need booster sessions. We need to prepare patients for relapse, because what happens in therapy sessions is not often generalized to real life situations. We don't plan what are the potential factors that may contribute to relapse and how do we handle them. Then I think you have an exposure staring at your face very soon. So if I have to summarize, in addition to many factors that I talked about, I think the most important thing is untrained and inexperienced therapists. I often get to see that I received CBT and how many sessions, 10, 15, and you find out what they have done. Most of the times there is symptom analysis, and then some simple supportive therapy, and after that relaxation. One kitchari of things that are done. In fact, CBT is a kind of a term which is used very loosely, and not necessarily the active components of CBT are often employed rigorously. Active components of CBT are exposure, response prevention, and a cognitive restructuring. Without these three components, there is no CBT. Now, therapists often lack patience because you don't see improvement quickly. And therapists sometimes are as inflexible as patients, even setting the agendas for therapy. They sometimes get into argument with patients and fight with them as to why they are not done something. Now, and then if they don't do the work, they don't done the homework, they don't want to see those patients, or they lose interest in them because they're not a good advertisement for you as a therapist. Now, very, very prescriptive approach without a shared or a collaborative understanding, using poor techniques and not involving family. I think these are some of the things which I have come across in my supervision of CBT for inpatients. I guess these things also apply to um, less severely ill patients, moderately ill patients whom we routinely see in our outpatient practice. Now, I'm coming to a little more controversial kind of thing. Now, TMS is widely available. Now, to that you have TDCS. Now, people want quick remedy, and we also fall into the trap. There are unrealistic expectations from non-invasive neuromodulation. Neuromodulation is an exciting area for research, but there is no need to be so excited about it because they may be partially effective in a small proportion of patients, and the benefits are not actually seen beyond few weeks. Even the recent FDA approval for a deep TMS or simulated cortex, if you actually read the paper, it is not as great as it sounds when you read the abstract. In fact, response and remission rates are very low with a very, very liberal definition. And there is a fall of about 5 to 6 points in Y-box score. While it's encouraging to think that TMS works, it is also true that it is a useful treatment armamentarium, but using TMS TDS as a drop of a hat as a problem. What is that? You are actually withholding more effective treatments by generating unnecessary hope in the patient about TMS TDCS. In fact, these should be kept. I would say TMS TDS are the treatment that needs to be kept when other frontline treatments don't work, rather than offering hope with TMS TDCS. In fact, these are very, very common questions that I get from patients. I get mails about TMS TDCS. And it is definitely not an option in treatment resistance. I don't see, at least, although if you read articles on treatment resistance, TMS TDCS, they do crop up, but read the fine print, they're not great options. They're one of the options. Okay. So they should not be oversold. That's my point. This leads to delayed use of treatments such as CBT. Does ACT work? I think, my answer to this is clearly no, unless there is a severe comorbid depression. Now, what are other mistakes that we make is that we don't often use inpatient intensive treatment for OCD. There are a group of patients who can actually benefit substantially if you actually give inpatient treatment, where you do a rationalization of pharmacotherapy. You also do a very intensive CBT program, which is monitored on a daily basis. Okay, it is time consuming, a very intensive program. So you need to have enough people to do that. Okay, many times it is feasible in the institution. I would say it is feasible in most medical colleges. It's just that we need a motivation to do that, because every day you have to spend about 2 hours with the patient. Now, medical colleges are a place nowadays to do this because there are postgraduate students who can participate in this. The reason I'm saying this is we do not really have too many effective treatment options for OCD. So we should make use of all those options which are of a potential benefit. Okay. And one of that is the inpatient treatment, or what is regularly called as intensive residential treatment. We have been offering this intensive residential treatment for more than 25 years, but we have not really analyzed the data. We recently analyzed the long-term outcomes of intensive inpatient care for a severe resistant OCD in our clinic, where we examine our outcomes in about more than 400 patients. About 60% of the patients have shown a good income. You can see that the Y-box had fallen significantly and the improvement was persisted in, of course, there was a dropout, but as long as 2 years. So the N was 420. If anybody is interested, they can read that this article, which has appeared in Canadian Journal of Psychiatry very recently, I think in 2020. This is a very ambitious work for us because we have been doing this work for about 25 years, but we are not shown anybody that it can work, because there is always a pessimism that this may not work and it's too time intensive, cost intensive, and not worth doing it. Now, we also did, in fact, one of our students looked at it prospectively. This was a retrospective study, because you can't get 400 odd patients in any study. That can only come from your hospital admissions. All of them were admitted. Now, one positive prospective study by one of my students and my other colleagues also came up with a similar results of a good response. At least about 60% of them do well at the time of discharge, and many of them, the remission is maintained. So we need to use this option, and in patients who are severely ill, who don't respond to SSRIs and to outpatient CBT. Okay. Now, I also think it's a mistake not to offer surgery. Now, there are patients, let us accept this fact that there are about 10% of the patients who are really sick, very, very sick despite what you do. They are so ill. In fact, some of them are so ill that you can't even think of doing CBT. Okay. CBT is also should not become kind of like a religion, that it has to work. No, it doesn't work. Like SSRIs don't work in about 40% of patients. CBT also does not work in about 40% of the patients, and about 25% of them actually drop out of therapy. So when that is the situation, there are patients who are extremely ill and suffer from a chronic disabling illness. In them not offering surgery, I think not a great idea now. But at the same time, what are the pitfalls in surgery? Now we have two extremes. There is a low threshold for surgery. Some people offer surgery very quickly. Patients also ask for it, thinking surgery cures OCD. There is nothing that cures OCD. It only improves the clinical condition. And then there's one extreme. The other extreme is not offering at all surgical option to very, very severely ill patients, because we don't like surgery done for psychological disorders. Okay? But what families and patients should know is that about 50% of them improve with the DBS or even lesion-based surgeries. Okay, and there is a lag in the onset of action. Sometimes it takes 6 months to 1 year after you perform surgery or deep brain stimulation when you actually, start treatment. So, and during this time, other treatments have to continue. That one gets surgery done and OCD is cured, and I don't have to use SSRIs. Now, this is the idea that most patients have. So we need to handle them. So we need to offer surgery to right patients rather than withholding them. Of course, not all centers have facilities, but I think increasingly there are neurosurgeons all over the country who are willing to do this. If sufficient precautions are taken, we can actually encourage surgery. I end my talk with a few research articles you may find. This is a review that we wrote on OCD in Nature paper, along with my collaborators from US, Brazil, South Africa, and Netherlands. This is just a figure, but there's a full-length article is available. Good article for post-graduation and others, which covers most aspects of OCD. And of course, this is something that we all are familiar with, clinical practice guidelines, but is also a couple of years old by now. Recently, International Clinical Psychopharmacology has published a position statement on OCD spectrum disorders. Some of us are co-authors who have contributed to this position statement. This is also, I think, readily available for people to read. There is a good review in JAMA some years ago. Of course, we are not enrolled in this, but it's a very good review to read. Then there is a neuroscientifically informed formulation and treatment planning for patients with OCD. Very, very interesting article published in JAMA Psychiatry in 2018. And we have written some years ago about augmentation strategies in expert review neurotherapeutics. And then there's one paper we wrote, what are the commonly asked questions in the treatment of OCD? FAQ, it's a kind of an FAQ. Most of it is, although it's about 4 or 5 years old, maybe a little more, 2014, but all the questions are relevant even now because nothing really has changed significantly. Thank you, and I can take questions.
Thank you so much.
Thank you. Amrit, you want to go ahead?
No, sir. You, sir, first.
Yeah. Thank you so much for that very scholarly description, Dr. Janardhan Reddy. I think it is what is expected of you, and you lived up to that. we have a lot of questions. I think the first salvo had come from the CNMOS psychiatrist, Dr. Ajit Vide. He asked, is clomipramine not superior to SSRI? Is it inferior? Well, I am reminded of the routine, regular proverb saying that if the younger daughter-in-law is good, does it mean the older daughter-in-law is bad?
Well, Adit, no, I will answer this question slightly differently. Like Ajit, I would also like to believe it's superior to SSRIs. Okay, I would like to believe so. But unfortunately, it is not. It is not inferior to SSRIs. Let me tell you, it is not inferior to SSRIs, but it's not superior to them. The reason I'm emphasizing that is, giving it as a first line option has its own problems. But having said that, I should also admit, after 2 SSRIs, clomipramine has to be tried because ultimately we're talking about a network meta-analysis. If 2 SSRIs don't work, if patients can tolerate, and there is no CBT, I would definitely give clomipramine.
Okay.
So can you stop the screen share so that you are visible on the screen?
Okay, I think, yeah.
Yeah, thank you, Dr. Y.S. Janardhan. And another question comes is that suppose the patient has a severe acidity with SSRIs and intolerable drowsiness with clomipramine. What the other choice?
Well, the other choice is do therapy.
Right, good. Thank you.
But then all SSRIs are not equally bad to your gut. Maybe some drugs such as sertraline are bad, but I think you can try one or the other drug. They might work.
Yeah. So maybe you have
But
answered.
then but persisting with SSRIs, saying this is the only treatment available, is not fair enough. I think if they're not tolerating, I think we should try and offer them therapy.
Maybe you have answered Dr. Vivek Kirpekar's question. If one doesn't respond to one SSRI, next choice should be another SSRI or different group?
Well, I think there is no other group. There's only SSRI which works for OCD, another SSRI. At the most, whether you can think of whether to give clomipramine and SSRI, but I would use probably another SSRI if there's no improvement. But I emphasize at all levels of treatment, CBT is an option.
Okay. Oh, then
Dr. CBT is an option.
Yeah, Dr. Paramveer's question is that is clomipramine superior to other TCS?
Of course, that's there are very big studies done. In fact, when clomipramine came to market, there was a need to. I mean, it was a serotonergic drugs. Okay, they compared with the non-serotonergic tricyclics, and they showed efficacy. I think good articles have come in. What is now JAMA psychiatry, then was archival psychiatry. So yes, it's true. That's why the serotonergic hypothesis came into discussion.
Okay. You were mentioning about the duration of treatment. A question from Paramveer again is that shouldn't patient be aware of lifetime requirement of these medications?
Yes, there are situations where you need to discuss them. There are situations. I would not do that if I see a patient with OCD for the first time. Okay. It is not something that can be rapidly prescribed. If somebody comes to me with an year or two of OCD and they've never been treated, I will negotiate with them for a treatment, and if it works for a couple of years, and then try and taper it off. Okay. Now, I will also warn them in the process of tapering, if symptoms come back, either you need to go back to SSRIs, or if you think that SSRI is not an option, then we try CBT. But there are patients, a large number of patients, where an indefinite treatment with SSRIs is required, provided they work for them. You don't give them if they don't work.
Okay. Again, Dr. Ajit Vide has the first line augmentation with earlier was with, I'm sure it is buspirone, and is it disappeared? Has it disappeared?
Yes, it has disappeared. It has.
Okay, good. I think that answers the question. So another question is, why not short-term benzos? Are they useful?
See, all of us use benzodiazepines, either for a sleep or, they somehow make you, many of these patients also have free-floating anxiety, and, you want to calm them down. But benzodiazepines don't have any anti-obsessional property. Although there was some interest in the anti-obsessional property of clonazepam, somehow the interest has disappeared. All of us use clonazepam. I'm no exception to that, but I have not seen any patients OCD improve with clonazepam. Sometimes they become a little more kind of less agitated, less restless, they may sleep better. So all these things can help a patient.
Okay. Any comment on role of mood stabilizers in OCD? Another question.
For some time, lithium used to be considered as an augmenting agent for OCD, which is not the case anymore. But mood stabilizers are the treatment of choice in OCD if OCD is episodic and can be understood as a part of bipolar disorder. I would not recommend SSRIs. There are a group of bipolar patients where SSRIs appear only in depressed phases of bipolar disorder. So in such patients, mood stabilizers are a priority and not SSRIs. Of course, there are situations where you may have to use them because symptoms still persist, but that's a different kind of a discussion. But in the non-comorbid, I would say patients who do not have bipolar disorder, mood stabilizers do not have a role, although lamotrigine is being used as an augmenting agent now. There is some evidence that lamotrigine can work as an augmenting agent in OCD.
Okay. So another interesting question, is the response rate different in older patient compared to the younger ones?
Okay. Let us say if an adult patient comes and sees you and tells you that I have had OCD for the last 25 years. That means when I was a child and even now I have an OCD, that is an indicator of a poorer prognosis overall. Early onset adult OCD has a poorer prognosis. But if a child with OCD who does not have many comorbid conditions, let us say a 10-year or 12-year-old child comes with OCD, the outcome may not be bad. In fact, it may be slightly better than in adults. The persistence rates of OCD from childhood to adulthood are not really very high. So childhood OCD probably has a reasonably good prognosis. Of course, it has its own problems of other comorbidities, but adults with childhood onset OCD definitely, is one of the well-recognized indicators of overall poor response and a poor naturalistic course.
Okay. In the beginning, you were critical about antipsychotics to start with in the very early days of treatment itself. So adding antipsychotics, Dr. Supriya Mathur asks, do you think when should somebody add antipsychotics? Most probably you already mentioned it as an augmentation, isn't it?
Yes, let us say I give fluoxetine, they have partially responded, then what do? There is a response, but there is a partial response. Should I add an antipsychotic or should I add CBT or ERP? Now, if there is a good therapist, I will add ERP.
Okay.
If there is no good therapist, I will add risperidone or aripiprazole.
Okay. So another interesting question, if somebody responded to SSRIs, should we taper it off and start CBT?
I know. This is an interesting question because many CBT therapists who are very passionate about CBT believe that if they do CBT, they can reduce the dose, ultimately wean you off SSRIs, and then CBT has empowered you enough to fight OCD. Now, this is the most ideal situation I can imagine, but there is no data to support this. And unless, I can try this only in a very, in patients who have responded well to SSRIs, but cannot tolerate SSRIs or cannot continue SSRIs for whatever reason. In such patients, if there are still some symptoms, then yes, CBT can definitely be tried. But CBT in general is believed to reduce relapse rates, and in general, it is believed that CBT has long-lasting effects compared to SSRIs. Now, but the evidence supporting this is rather thin, and I somehow, you can call me, despite all that I talk about evidence-based, I'm not such a great fan of CBT beyond a point.
Okay.
There's no evidence to say that.
Yeah. My younger friends, Dr. Sagar Lavania asks, what are the drugs for, in pregnancy, the one which they showed response or an alternative should we think about?
Well, I would avoid paroxetine. If I have to answer one question, I will avoid paroxetine.
Okay.
Now, other drugs are, of a similar kind of a risk.
Okay. Then the senior friend of mine, Dr. Vihangwa here says, risperidone itself induces hyposerotonergic state and treatment-induced OCD. Do we still use risperidone in OCD?
Well, this is a question, this tough question, okay, in some way. You know, you give risperidone, but risperidone itself induces OCD symptoms, isn't it? Now, but the risperidone inducing OCD symptoms is seen in patients with schizophrenia where higher dose of risperidone, like 6 to 8 milligrams, is given. But in OCD, you actually use a much lower doses. Now, whether it is the anti-dopaminergic properties of risperidone or whether it's serotonergic properties of risperidone contribute to its efficacy, we don't know. There is a theory that antipsychotics with the potential D2 blocking property are the best augmenting agents. So in that list, risperidone is quoted. Now, aripiprazole has no serotonergic properties at all. Okay, so the exact mechanism is unclear, but it's true that high dose of SSRIs are the usual therapeutic dose of, usual therapeutic dose of antipsychotics in schizophrenia have a tendency to induce OCD symptoms, but not risperidone doesn't cause those symptoms in not so commonly, unlike clozapine. Now, clozapine, we know that is a medicine which can induce OCD symptoms. It can also worsen OCD symptoms.
Do we have any study to think either risperidone is better or aripiprazole is better as augmenting agent?
There is no head-to-head trial.
Okay.
These are all
it's only
analytical findings. Yeah.
Okay. Another question which we have is that suppose the patient has clomipramine induced seizures, do we use anticonvulsants or what will we do?
And if clomipramine is effective in that patient in treating OCD, okay, and I don't want to lose that gain made, I will add an anti-epileptic. But I will not continue clomipramine if clomipramine is not working.
Okay.
Raju sir, can I ask a question?
Please.
Reddy sir, what is the uppermost dose of clomipramine that can be tried, or that can be, or the high normal, you can say the upper normal, beyond 225? Have you used? What is the frequency?
I have not used. Dr. Sumant Khanna, my teacher and a friend, was very fond of using 300 milligram of clomipramine. I am scared of using that. I have never gone beyond 225, but you can go up to 300 milligram. Yes, the upper dose is 300 milligram.
And sir is very, very clear about the fact that you should not use fluoxetine beyond 80. We had a lot of discussions
I am
about
very,
it.
very clear about
He's
it.
very clear about it.
I see 120 very frequently.
Shall we come back to the audience questions?
Yes.
Next is Dr. Amandeep asks, would the patients with obsessional type of OCD be better served by maybe ACT? He means perhaps anticonvulsive therapies.
No, it may be acceptance and commitment therapy.
Acceptance and commitment.
Yes.
Oh, sorry. I'm sorry.
Yeah.
I'm really.
These are new waves therapies. Yes, it can be useful, but of all the psychotherapies, CBT involving ERP is the first line treatment. Nowadays, mindfulness-based therapies, ACT, and all these things are coming up. But yes, it's possible to use them. But I think I would still say standard CBT is the first line treatment.
Okay. Another is the sexual dysfunctions. As far as SSRIs, then what would be the deal? How to deal with that?
Well, if you're using very high doses like 60 or 80 milligram of fluoxetine and you have a sexual dysfunction, try and see if you can reduce to 40 and sexual dysfunction improves. Okay, because 40 is not a bad dose. Okay, of course there is a chance of worsening of symptoms, but try and give moderate doses. With some drugs, they use weekend holidays. Take exercise for 5 days and don't take for 2 days. And then drugs like bupropion is widely used for a range of sexual dysfunctions. And after that, is all like any other drug-induced side effects. I think bupropion has the best evidence in terms of treating sexual side effects. But sexual side effects is a big issue. See if you can change over to another SSRI. Paroxetine is the one which has maximum problems.
So, and here vilazodone, role of vilazodone, have you used it?
I have used it out of frustration sometimes because in the sense I have a large number of, I talk like this, but I have a large number of patients. I don't know what to do when they come to see me, actually, frankly speaking. So I have tried vilazodone in some people. I really can't say much about it, but I've given it because it also is a serotonergic drug. I don't know.
Okay. So one from Dr. Pooja Gupta, if somebody has, she specified schizotypal, but personal disorder with OCD, which would be focused first, personal disorder or OCD?
Well, I think you'll have to handle both because patients come to you with severe OCD and you recognize them to have personal disorder. There are some personal disorders which contribute to poor outcome. One is OCPD. The other one is severe PD, such as borderline personal disorders, can contribute to poor outcome in treatment. So they have to be simultaneously handled. Otherwise, it's a well-known that comorbid personal disorders predict poorer response treatment, particularly CBTs.
Okay. Role of mindfulness in management of OCD.
Well, I mean, it is gaining some importance now. It basically mindfulness is to simply to say that not to interpret or appraise thoughts, become an impartial spectator is something which the old brain lock keeps talking about it in a different language. So mindfulness therapy is being increasingly used now. In fact, we ourselves have done a couple of randomized control trials as part of the PhD thesis of some of my students. In fact, this month, I think we have published a RCTF mindfulness based treatment in OCD, which showed positive results. If you ask me, I myself don't have any competence in mindfulness, but psychologists in my group, some of them are quite interested in practicing it. But yes, I think it has a role, but evidence base is still thin compared to CBT.
Okay. Dr. Vishal Sinha's doubt about best drug in pregnancy in OCD.
There is no, I mean, there is no best drug in terms of, I think citalopram, sertraline, all of them are okay. I mean, I don't have a favorite. What I know is that I don't want to give paroxetine.
Okay. Dr. Anindya Mandal asks, in case of OC with poor insight, should we start antipsychotics or treatment should be started only with SSRIs and CBT?
Yes, I think I would prefer the latter, SSRIs and CBT. The reason I keep saying about not using antipsychotics is that antipsychotics really don't work as well as we think they should. Now, all the trials of antipsychotics that are published are routine OCD patients. They're not poor insight OCD patients to say that they work in poor insight OCD patients. Now, intuition tells that if there is a poor insight, it's much closer to psychosis and it might respond to antipsychotics. It doesn't happen. Let me give an example of a body dysmorphic disorder where 25% of them are delusional and another 50% of them have poor insight. Even in those patients, antipsychotics are a disaster. They don't really work. But after some time, you will end up trying these things because not easy to treat OCD. But if you ask me if there is an evidence to say that poor insight OCD patients respond better to antipsychotics, the answer is no.
Okay. So Dr. Vishal Sinha is back with a question that risperidone, olanzapine, aripiprazole, which is the best for augmentation?
Risperidone, olanzapine, and
aripiprazole.
Well, I would prefer aripiprazole simply because it does not cause weight gain and sedation. And I think nowadays people say that aripiprazole may be slightly better than risperidone, but nothing to really choose. But I think the side effects choose themselves.
Okay. So, Dr. Anna asks, if the patient has psychosis with OCD symptoms, psychosis responded to clozapine, what are our options now?
Yes. If a patient with schizophrenia has responded to clozapine and has OCD, there are two things. We should see whether OCD has been present even before clozapine was started or OCD is clozapine induced. Now, if OCD is clozapine induced and is very severe, try if you can reduce the dose of clozapine and if it improves OCD. If it doesn't, then there is a suggestion that you can add aripiprazole, which may be somewhat effective in treating drug-induced OCD. Of course, we can use SSRIs. I mean, I've been using them, but there is not really a systematic data to dictate treatment in such patients.
Okay. So, Dr. Jolly asked, does EMDR any role? How robust are the studies?
What is it? EMD?
EMD.
What is EMD?
I'm not very sure. EMDR she wrote anyway.
EMDRs, eye movement.
No, that one is used for PTSD. No.
Okay.
No.
Okay. Anyway, good that Dr. Vihangwa here thanks you and also thank me too. Does buspirone work for obsessions?
Sir, 1 minute, I will connect my. I think the power is going off in this. Just give me 30 seconds.
Okay. Anything, Alim or Amrit?
Yes,
Can
Yes,
we
sir.
go on or shall we?
No, we can go for 10, 15 minutes.
10
A
minutes.
lot of questions we take down.
Yeah, there are a lot of questions. Should we stop or should we go on? I think that you should tell me.
We can take another 5 to 7 questions. Okay.
We can go on.
Put the time,
I-
not
I
the
will
questions. Put the
Dr.
I
Tufan
welcome
sir is there.
Dr. Raju.
Sir.
Yeah, Dr. Tufan,
Dr.
your comments, please.
No, not. Yeah, I am sorry that I was little late because of network glitches.
Yeah, I saw that. Yeah.
So I realized it at the last moment, and I had to solve it. There is disconnection.
Oh, it is sad. Big
This
number out here.
cable connection has been disconnected somehow by some miscreant or someone.
Oh,
So the first 10 minutes I was busy in serving that. Still, I thank you very much, Raju, and welcome you.
No, Tufan, it is my privilege, Tufan. I think
And Dr.
I'm
Nistal,
really.
thank you very much for accepting the invitation immediately. I would have.
No,
And-
thank you.
Yeah, Janardhan sir.
And Dr. Reddy,
I think he is
told
getting
your-
his mobile.
Yeah, it's on. It's on. Yeah.
It's on.
Yes.
So thank you, Dr. Reddy. I have not had the first 10 minutes. I was barred by the network. I will make up for it and welcome.
Thank you, sir.
Yeah,
You
Janardhan
can
sir.
continue.
Janardhan sir. Sir, please tell me, you are an authority on OCD. You are sitting in a tertiary center. People are looking up to you. So it might be easy for you to say to patients that wait more. What about the junior practitioners who are sitting in independent clinics? So how should they handle this thing? Because
even senior practitioners, Alim.
No, get me once again. I didn't get a question correct. You are saying that in tertiary care centers, you are saying something.
Yes, sir. I am saying that you are in a tertiary care center. You are an authority on OCD. We all look up to you. So it is easier for you to say to the patient that wait a bit more.
Okay.
And it is not what should a junior practitioner do who's
Okay.
in a independent OPD?
I get your point. I am not fully convinced, Alim, this is about the seniority. I think the issue is that we need to tell them we have a treatments for your illness, but there are no treatments which do magic. Okay, and what all we know is that they take time to work, so you need to wait for them. I don't think they expect faster response. Of course they expect, but there's out of ignorance. But if you're able to tell them that these medicines by their very nature work slowly, for example, you treat tuberculosis, isn't it? You treat tuberculosis, you tell them these 9 months or 12 months. Do you think it is difficult for a PSC doctor to tell them? No, it's not. No, it's not. Oftentimes we don't tell them, this requires some time to talk to them. That, I'm giving a medicine, it takes about 8 weeks. Please be patient. It doesn't show response quickly. All that we need to do, talk science to them. We don't need to talk science to them. Then I think they will accept. And one good way of talking science is to give them some booklets which talk about OCD. And many people like when something is given in a printed booklet, they believe it is true. Like all of us believe all published articles are great. They also believe that whatever is given in a printed format is great. So give them a booklet which explains all this. I think that makes things a little easier for them.
Yeah, Dr. Janardhan, an interesting question. Not only that, it is quite exciting for me is that suppose the patient has bipolar disorder with OCD. If you are to use an anti-OCD treatment, how do you do that?
I would first stabilize them very well on a mood stabilizer first, and preferably also an atypical antipsychotic. Most bipolar patients now have a combination of a mood stabilizer and an atypical antipsychotic. So there's a good mood stabilization. Once I'm sure that there are stable
Any
doses
preference
of
for mood stabilizer?
any preference. No, I think the mood stabilizer should be, choice of mood stabilizer should be that depends on the disorder of bipolar, treatment of bipolar disorder, not on OCD. So either a valproate or lithium or a combination of them or a combination of mood with antipsychotics, any of them is okay, but they should be on a stable doses, adequate levels, and then you slowly introduce an SSRI.
Do you use SSRI there?
I use, yes, of course. I mean,
With risk of switch?
the risk of with SSRI is obviously low compared to tricyclic antidepressant, but then
Okay.
it's not very high. I mean, recently we have reviewed our data. I think one of my students reviewed all that. We may publish like a small report with the retrospective data because we use them quite extensively. Even a place like Nimans, you cannot do therapy for every OCD patient who comes to you. It's not practical for a variety of reasons. So for us, still pharmacological treatment is a first-line treatment for many reasons. So we should do a very rational pharmacotherapeutic practice. I mean, that's the first thing that we need to do before we really talk about CBT a lot.
Okay. Another question is from Dr. Nidhi Jain. Usually earlier relaxation techniques and all were not indicated in OCD. Do you still continue to have that, like meditation, relaxation?
Yeah, relaxation exercises definitely, do not work for OCD. Now, meditation and yoga, I don't think there is any evidence, and whatever little evidence is there is not of a great quality. And I'm not particularly fond of prescribing yoga or meditation to OCD.
Okay. Another question, some unknown, but says, when do we keep on increasing the doses? Where do we stop increase doses as far as maintenance is concerned? Like, the question is that where do we stop? Increase it to what level should we increase the dose? Or
I
something
think
like
I showed a table. Beyond that, we should not go.
Okay.
There is a table. You can't go beyond 80 fluoxetine. You really don't go beyond at the most to 300 milligram of sertraline. You don't go beyond 40 of escitalopram. You don't go beyond 300 mg of fluoxamine. So upper dose range is more or less widely accepted.
Okay.
Sir,
Anything, Ali?
Augmentation. What is the point when the augmentation should start?
If there is a partial response to an SSRI, or let us say you start for the first time you're seeing a patient and you've given an SSRI and patient is on SSRI for 5-6 months. You have done an extended trial and you still think that patient has improved, but still not enough, and CBT is not an option, and that is the patient I would give risperidone or aripiprazole, one option. Now there are situations where I've tried everything, multiple SSRIs. They're not non-responders, but then they're non-responders, not partial responders. Even there's a case for adding risperidone or aripiprazole. So aripiprazole, risperidone are used as augmenting agents in partial responders and non-responders as well.
Okay. Any difference of switch with different SSRIs or all the same?
Looks like they're all same. Looks like they're same.
Yeah.
Looks like they're same.
Okay. Another Jain comes on with a question. Has anyone studied the efficacy of trauma-focused psychotherapy in OCD?
I don't know.
We don't know. How long should we continue medication for OCD is the question from Dr. Nidhi Jain again.
I think I presented it at length. First episode OCD, if patients remit, continue at least for about 1 to 2 years, and then even when you withdraw SSRIs, do that after discussing with the patient, discuss the potential chance of a relapse upon discontinuation, and the need to reinstitute medications or therapy if required. I think all these things have to be done.
Maybe we will have the last question because if you keep the screen on, many questions come in. Memantine OCD, that would be the last question.
Yes, of the glutamatergic drugs, memantine probably has the best evidence. I also use them, but like I said, they're not a great drug. Some of them may improve.
Okay. Thank you, Dr. Vais Janardhan Reddy, for excellent, as usual, the presentation and a lot of questions. And I think perhaps one of the biggest audiences we had for this series. And Again, as at the beginning I thanked, and at the end also I thanked Dr. Tufanda for giving me this opportunity of chairing a very, very exciting session with Dr. Vaisi Janardhan Reddy. And thank you, Alim. Thank you, Amrit. And I hand it over to the organizers.
Sir, may I
Anything,
also-
Dr. Anil Nishal?
Dr. Anil sir. Dr. Anil.
Yeah.
Yes. I would also like to thank Dr. Janardhan Reddy for a very, very lucid and a beautiful presentation. Actually, the topic was very simple, so to see, but then simple things actually are difficult to address. Common errors in management of OCD. Sir, you have done a wonderful job and
Thank you.
taken us through the diagnosis, the evaluation part, the management, different aspects, pharmacological, non-pharmacological, neuromodulation, surgery, everything. You have covered it very well. So I wish to thank you so much that you have crystallized all this and organized all this for this forum. All of us know a few things here and there and we think about it, but the job of bringing it all together was beautifully done. Thank you so much. And I would
Thank you, sir. Thank you for giving me an opportunity.
thank you.
Thank you, sir.
And thank you, Tufan sir. Thank you so much. Thank you, Alim. Thank you, Amrit. Thank you.
Thank you, sir. Over to Dr. Tufan Pati, sir. Sir,
So I have already
your remarks.
mentioned I am very much unfortunate. For the first I missed 10 minutes of the talk today, and that too of Dr. Reddy. And I think I should make personal calls to compensate for that. And the talk was very nice. Whatever I heard and the discussions are very enlightening. And I am thankful to all the chairpersons and the speakers and the team, Trust Amusing, for a grand show. And I hope henceforward I shall check the network half an hour before the program. I just try to open up the no network. Absolutely, the box is not showing.
So,
Thank you, everybody. And again, I express that I am sorry for the delay. Thank you all.
Thank you, sir.
Dr.
Thank you for giving me an opportunity. I must especially thank Amrut for having pushed me to do this. I was really reluctant to do this because I thought people will be bored with this because I have spoken about variations of these topics so many times. So I asked him whether some of my colleagues can do, they can give a fresh perspective, but he insisted on the fact that I should come. Thank you, Amrit, for giving me an opportunity, and Alim and my friends, Dr. Raju, Nisil, and then Dr. Tufan Pati. Thank you again.
Sir, let me give a formal thank you from the IPS Odisha branch. Sir, Dr. Janardhan Reddy, crisp, clear. He made such a complicated subject look so easy. So thank you so much, sir, for coming on a, you always are there for us. IPS Odisha, you also remember the number of times you've come and spoken. Every time you bring a fresh and new perspective. Thank you, sir. You're an authority and you have proven today why you are an authority, sir.
Thank you.
Thank you, Dr. Raju, sir, our president-elect. So thank you for accepting our invitation, and we are lucky the Odisha State Branch could host you. We think that you belong to us. You are Odia by heart, and thank you for obliging us and coming on board and making mine and Alim's work so much easy. You took all the questions. You covered maybe 40 questions in 20 minutes. 2020 cricket like the test match we had today, sir. Thank you so much. Thank you, Dr. Anil Neschal. Lovely smile you have. Sir, thank you for being so polite, kind, and considerate, and being such a good chairperson. Thank you, Alim. For the first time, I saw you silent, and you were given the silent treatment today, and I think you deserved it. Thank you to all our dedicated, followers. Let me tell you, today we have more than 750 registrations, 500 participations, and that's too much, sir. Dr. Janardhan Reddy was telling there is a flood of people who are coming. The number of webinars, people have got webinar fatigue. But then if you have 500 participating, I think it calls for a celebration, sir. Thank you, our organizing team.
It really does. That is because of Dr. Reddy.
Dr. Reddy and Dr. Raju.
And Raju, sir. And I have to thank Raju,
and Dr.
sir,
Anil also. Please don't mind, but then, sir. And thank you, Odisha State Branch, for supporting us, helping us do this event. Thank you, Dr. Tufan, sir, Dr. Alim, Torrent, and Pawan in particular, who has been helping us. Good night, everybody.
Good night.
Next time.
Yeah.
Thank you.
Thank you, everybody. Good night, everybody.
Thank you.
Yeah. Good night. Bye bye.
Bye. See you. Thank you. Thank you, Dr. Nischal. I
Thank
could
you
not
so
have
much,
the
sir.
initial
Thanks
chat
a
with
lot.
you.
Thank you. Thank you, sir. It's a pleasure. Thank you.
Sure.
Close the
So
from my side?
I think we should close the meeting.
Yes, sir. I'll close it. Yeah.
Still, there are 50 plus persons.
Yes, sir.